who are from Swiss Balance. There are a number of good orthotics groups around the area and around the country. We've been working with Swiss Balance who've come to the clinic and really are very helpful in helping you figure out the braces that you need. One of our goals, as you know, insurance is not in love with making multiple different braces all the time. So one of the things we like to do is make sure that you get the right brace the right time. So that's where a very good orthotics person comes in. So Dave?
Thank you, sir. Good morning. If I wasn't nervous enough this morning, I have the ever-observant Dr. Pfeffer to thank for coming up to me and saying he didn't know it was a no-tie Saturday. But I wanted to tell him that I would have spent the whole morning kind of tugging at my collar if I had, but I had to tell the truth and tell him I don't own a tie. So I would like to thank Drs. Lewis, Dr. Pfeffer, and Dr. Balo for having invited Swiss Balance to become a member of the Cedars-Sinai CMT clinic and provide this opportunity to speak to all of you briefly about orthotics or bracing and the treatment of CMT. What my colleague Rudy and I hope to offer you is an explanation of the authorship of much of the slides you'll be seeing, just who Swiss Balance is, and a short list of clinical information about and orthotic treatment options in the presence of a CMT diagnosis. To start off, I'd like to acknowledge the primary authorship of much of the slide presentation. After we were apprised late last year that we would be part of this conference, Rudy and I both set to scratching our heads and wondering what in the world we were going to present and how to put it together, and all the other worrisome aspects of presenting information to a group. We had both had recent lectures about prosthetics to much smaller groups. So we had a plethora of pictures and supportive data, but our library of CMT-related pictures and information was practically non-existent, given our short time with the clinic. Got to figure out how to use this. We both started to see what information we could gather, and like any good American, we went to the internet. And that's how I found Mr. McHale's name. I went to a CMT Association website, which is just an amazing website. You could spend days on there if you haven't been there yet. And Mr. McHale's name kept popping up in all of the patient forums, so I took the liberty of emailing him and seeing if he would perhaps share his experience with CMT, and we ended up speaking. And he offered that he and his colleague, Mr. Meisner, had just recently done a presentation in Orlando, and he would be more than happy to share his PowerPoint with us. Hence, I wanted to give them full credit for much of the slides you'll see, although we threw in one or two. This is me, a little larger picture than necessary, especially this close to lunch. I'm a registered physical therapist as well as a certified prosthetist orthotist, and have been working in the field for a little over 30 years, 25 years at a facility near Cedars, and had worked here at Cedars for those many years. And I've been at Swiss Balance for 6 as of this past Tuesday. Rudy and I are both ABC certified prosthetists and orthotists, and it is a nationally governed certification body of the American Board for Certification. Our office, Swiss Balance, is only 8 miles southwest of here, just 15 blocks from the mighty Pacific. There are 6 of us that work at Swiss Balance, which is a private standalone facility with an on-site, fully serviceable laboratory for custom fabrication. And much of our association here with the CMT clinic is through an ongoing many-year professional affiliation with Dr. Pfeffer and his foot and ankle patients. We're honored to have his trust in our practice. We're not too far from the Santa Monica Pier. That's exactly what it looks like today. I'd like to tell you it's gloomy outside, but it's not. Swiss Balance is the brainchild of a great friend and colleague, Stefan Moser. We will be celebrating our 25th year providing prosthetic, orthotic, and pedorthic services in Southern California on the 1st of April of this year. That association would seem to benefit from a punchline, but I couldn't come up with one. On to the good stuff. I will be offering clinical presentations in CMT with some of the attendant biomechanical considerations. Rudy will be discussing the orthotic or bracing options. And with any interdisciplinary type of presentation like this, there's obviously going to be a lot of overplay with slides, although none of ours will be as good as Dr. Pfeffer's. This is clinically what we see in some common presentations, as you already seen, the high cavus foot with the hammer toes, intrinsic minus hands, which is important from the perspective in terms of orthotics of really being cognizant of donning and doffing a brace for patients who might have difficulty with grasping or a weakness in the hands. These are the basic clinical pictures that you'll see. I won't read them all off, but what we technically say in orthotic that they all kind of combine to what we refer to as an external rotary deformity, which we treat a little differently than an internal rotary deformity, which is more like somebody who has a flat foot or tends toward prolonged pronation. It's a gradual mixture of stronger versus weaker musculature that ultimately defines the clinical picture we see in CMT. The tripod effect that Dr. Pfeffer had mentioned as well from the predominant peroneus longus influence, generally setting the stage. We'll see this tripod effect, which the next slide will show the results of that more clearly, but it ends up with this varus angle at the calcaneus and a lot more weight bearing on the lateral side. And this just illustrates the progression of deformity in the foot. So that most of the weight bearing, again, ends up on the lateral aspect of the foot. I remember to bring my pointer. The opposite of an overpronated foot, where the forefoot exhibits a compensatory supination, we'll often see this compensatory pronation so that the foot has to come down to meet the ground, and in so doing, the torque on the first ray creates this varus at the calcaneus. And these are typical presentations of differing severity from a posterior view in that rotation problem. Evaluating the foot in both a non-weight bearing and weight bearing situation can give us a better feel for just how much correction versus accommodation we can obtain at the ankle of the foot, provided there is some mobility that we can address. Without mobility, we're totally accommodating, and that's not often a successful intervention. Given a mobile subtalar joint, or at least a neutral position calcaneus, this lateral wedging that you see here, we can sometimes build into the orthotic to in a way accommodating the plantar flex first ray, but more importantly, giving the foot a full contact and balanced platform for weight bearing. Making sure, of course, that the calcaneus is as close to neutral as we can get a subtalar joint. Different methods of evaluating this positional ability include the Coleman lateral block test, which is a closed chain evaluation tool, weight bearing, that can reveal if the hind foot has flexibility that we might be able to address biomechanically. If the varus component of the heel corrects while the first ray is left non-weight bearing, first through maybe second sometimes, it can inform what level of excess we might expect from an orthosis. If the hind foot doesn't correct to neutral or some improvement in alignment, then there's less likelihood that orthotic intervention will be successful without accommodating that plantar flexed first ray. Also depends on how tight the gastroc Achilles is as well. Another closed chain analysis can be had from what's called a Harris mat impression. It's kind of like a Rorschach test for your feet. It's a full weight bearing image of the sole of the foot, which can define the high weight bearing areas of the foot. Here in the, I don't like that. The first mat and fifth will oftentimes, this whole lateral border will be just lit up with dark crosshatch patterns. The intrinsic posting that was mentioned before allows us to use a variety of relieving materials of variable densities to better address the high pressure areas and to provide a more total contact weight bearing area, a shared support, if you will. Sometimes it works and sometimes it doesn't. Sometimes relieving with a fenestration underneath the first ray can help, but then you start getting into problems with footwear, and Dr. Pfeffer had mentioned extra depth shoes, which we use quite frequently in bracing, but there are those times where we can get away with just regular off-the-shelf type of footwear as well. Sometimes even with all of these modifications, a patient might complain of pain in one area where he might have a callosity on the plantar aspect of his foot. So we go in and we fenestrate that area to see if we can't make it better. But what sometimes this addresses isn't so much that there's a problem at that part in the AFO, but if he's been wearing this or she's been wearing this for a while, it could indicate that the padding that we use may have compressed, which then changes the dynamics of the AFO. It can also indicate that there might have been some mitigation of the callosity or swelling on the bottom of the foot. And the combination of those two issues will change how the foot and the brace are acting dynamically. So rather than cutting out something to relieve, we might actually go in and pad it more to give that total contact surface back to the plantar aspect of the foot. These next two slides show what leads to these lateral surface changes and ultimately to the instability a CMT patient may feel during gait or even in a bipedal or static stance position where they might feel the need to always reach for something to balance themselves or someone else. Of the three planes of motion forces, side to side, front to back, and transverse, in normal gait, our center of gravity is basically just going through this little two-inch square module. It helps to maximize our energy efficiency. And anytime, if you're limping, you've got a sprained ankle, or you're walking on crutches, that center of gravity is going to go outside that little 2-inch square. Then you start to get these movements of the trunk that is not very energy efficient. With CMT, this outside pattern shifts the center of gravity to this outside line instead of coming from the lateral aspect of the heel to the fifth metatarsal head over to the first and off the toe. So this normal COG ends up coming out to the far outside, and that can create not only that imbalance that many CMT patients feel, but the increased energy and the need for ancillary support. And this is what evidences, as you've seen in other slides, this callosity on the outside, which as long as the foot's flexible and we can address it to mitigate the amount of external rotation, we can often reduce these as well as improve the pain profile of the patient walking. The whole trick is if what we make is going to make better than what they can do without it and still wear flip-flops, which is just a joke. Now I'll lend this to Rudy to pick up the discussion of orthotic bracing, and I thank you very much.
Good morning. My name is Rudy Parada. As David already alluded, I'm a orthotist, board certified. I'm going to touch briefly on an overview of basically foot orthotics. And I mean, there's a litany of them, and we actually have two of them in today's presentation outside, Dynamic Solutions and also Allard. And we'll be going over them briefly. Our initial evaluation that we start with is critical in discerning the appropriate device. The goal is to provide a brace that restores motion. To find out, we need a thorough evaluation, but more importantly, both the patient and clinician need to be on the same page. The last thing we want is to make a brace that ends up in the closet. And I'm sure some of you might have some in the closet, and we definitely don't want that. Our first traditional four goals have been our bread and butter, if you will, in the sense that they can be accomplished with a traditional plastic AFO, which has been around since the late 1970s. The advent of carbon fiber and epoxies have led to a dynamic assist orthosis. We can go a step further and call it an energy storing assist brace, which we sort of borrowed from the prosthetic field, particularly in the Pistorius gentleman who had the Blade Runners. And you can see that J shape really gives some energy back. This is only a small sample of the variations of AFOs out there. We look at these orthoses as tools, and we try to figure out which tool is right for you. I've seen a couple of patients here today, and all of them say, well, these are perfect. They do everything I want them to do, and each one of them has been wearing different braces. So there isn't one solution. We have to just figure out what solution is best for you. Let's start with the simplest orthosis, which is a custom molded foot orthotic. I believe that that's probably something that most CMTs ought to have. As Susan alluded earlier today in our personal conversation, she said one thing she learned was lateral post. Every patient she sees, she says, hey, you need a lateral post because your foot supinates out. If we could go ahead and put a post to prevent the foot from turning out, that would be beneficial. That will help you walk better. FOs incorporate posts, wedges, and elevations to relieve pressure or change angular positions of the foot and ankle. The next orthosis is called a supramalleolar AFO or SMOs. They're typically used in children and those foot and ankle deformities that are flexible and present without weakness. They will prevent further deformity and realign the foot and ankle. You see these a lot in children and particularly cerebral palsy, but they have a use also in the CMT population. SMOs are more conducive for patients with flexible flat feet. Patients who have high arches, which is typically a CMT patient, have a harder time getting used to these type of braces, but there are some CMT patients that do come in with pronation or flat feet that are flexible. Double action AFOs have adjustable settings for plantar flexion and dorsiflexion. They not only realign and stabilize the foot and ankle, but they can restrict motion and assist toe pickup via a spring. These braces are durable and robust, but they're bulky and heavy. We've sort of gone out of using these type of braces just because carbon fiber braces tend to give more dynamic assist, and the assist you get out of a spring is minimal, and they constantly break, and they're also pretty heavy, and most patients do not adapt to them pretty well, especially the female population. The two most common off-the-shelf braces used by CMT patients are what we call flow reaction AFOs. These braces will not only provide ample foot clearance and swing, they will decelerate the foot at heel contact and provide a resistance to tibial collapse. So if you're a person with a shoe size 10 and weigh 160 pounds versus a 200 person with the same shoe size, the brace will behave differently. So going custom is really the best way to go. That doesn't mean that an off-the-shelf will not work for you. You just have to hit those barometers pretty well. The brace on your left is a prefabricated AFO with flexible rubberized rods. The colorful one on the right is a custom dorsiflexion assist AFO. Both braces will assist the foot in clearing the floor, but the custom brace can be designed to realign the foot and ankle. So the plastic one has some, obviously picks up your foot, but also has some derotation qualities to it. This is called an ESR AFO. It's an energy storing and return that's made out of plastic. So the thought process has been there to give something that gives you some energy return. The drawbacks of plastic is that it does fatigue after a while. So whatever return you get initially, after a year or 6 months, you will not get the same return. And they're also subject to failure. The Silicone AFO is a custom-molded orthosis designed to assist in drop foot, provide total contact, and can be worn with or without shoes. The streamlined nature of this brace is appealing to some. Its original designer, I believe, is out of England. They do a great job of contouring this brace. It really fits almost like a sock, but it's limited to just toe pickup. If you have ML instability, it's hard to get that brace to accept posting. But the nature that it's so streamlined is appealing because you could really wear it in just about any shoe. Now we move into the custom laminated AFO sections. These are the braces that dynamically assist and provide energy return. These laminated AFOs are pre-impregnated carbon fiber. That is, they take a piece of carbon fiber that they know its inherent resistance and how it will behave under load and mold it over the positive cast of your foot and ankle. The amount of assist or resist is are based on height, weight, and the perceived functional level. Kinetic Research offers variations of custom molded AFOs, and the one on the left is a spiral design, and it's called the noodle, and it assists dynamically to prevent foot drop while also providing energy storing to improve gait symmetry. The middle orthosis is the noodle TA, which is a flow reaction design that optimizes the energy storing capabilities and also dynamically assists the gait cycle in stance and swing. The valgal noodle is essentially similar to the original noodle, but it gives you more ML control. This proprietary custom AFO design is manufactured by a facility in Las Vegas. It's called the Helios. It's very labor intensive and a precise tool that can be life-changing. The principles behind it are no different than what I have, Touch, or David, or Dr. Pfeffer. Really, the true difference and what sets it apart is the attention to detail. And the double helix by Dynamic Solutions, which are here today, and you could go ahead and fiddle around with it later, is also a proprietary design. It seeks to correct skeletal structural deformities and increase function. They're based out of San Diego, and just like the Helios, they could be a life-changing device. Now, functional electrical stimulation units like the Walk-8 and Bioness only help those patients with upper motor neuron lesions, and CMT, as hopefully we all now know, is a disorder that affects the peripheral neuropathy, peripheral nerves. I hope this presentation stirs some interest. Both David and I thank you for your time, and I don't know if we have time for questions, but if so, thank you.
We do have a few minutes for
We do.
questions.
Go for it.
Hands? Yes.
Are you making the SAFOs?
Am I making which one?
The SAFOs.
The SMOs. Yes, we do
No,
make
the
silicone.
yeah.
Oh, the Silicone AFO? No, we take a cast of it, but we do send it out to England to be manufactured. And usually the turnaround time is about a month.
And are people happy with them?
You know, it's a very limited population that wants the silicone brace just because it's really streamlined. It really only addresses the drop foot condition, and most patients that do get it because they want to get it inside a specific shoe.
After years of trying everything that's out there and knowing that a lot of people kind of go through a similar path, is there any belief on your part that there is a way to take, you know, what works for me doesn't work for him or for her? Is there a way to find a commonality so that anybody with CMT could come to your field, no matter who it is, and get some kind of consistency as opposed to going to Nothing But Love, 20 of you, and getting 20 totally different answers about what's right for one case? You know what I mean?
I actually feel your pain because it's true. There's no, you know, if one facility manufactures a brace, they might call it the same thing. Just like a laminated AFO, well, there's 50 iterations of that brace. But I think that if you go to a facility that has a good experience with the CMT population and has a good understanding of what you want and what function you want to attain, I think it can be done. At the very least, when you do an evaluation, try to get as much information and trial as possible. We try to have a good inventory of braces out there, and the first thing we tried are the prefabricated braces. Most of these prefabricated braces give us an idea of what potential you'll have. And we try to put an orthotic in those prefabricated braces. Because really, my thought process on prefabricated is 4 sizes fits none. It's just hard to get all of you to fit in a small, medium, large. So you need a custom orthotic to start with, and then you go, what brace will work for you? And you have to be logical in the sense that some braces will hinder your shoe wear, and everyone gets caught up in like, the shoes are gonna change. There's nothing any of us could do about that. There's nothing you could do about it, so it's almost water under the bridge.
You talked about energy storage with some of the braces. I think that was the expression you used. I don't know what that means. Could you define it?
Yes. Energy storing is, in prosthetics, when you go ahead and you load a strut and you put all your weight into it, it will go ahead and capture that energy, and as you take your weight off, it will have a spring-like effect. So, when you have weakness in the foot and ankle, not just for drop foot, but also push-off, you're lacking that push-off power, and you're also lacking that deceleration of when you make heel contact. You make heel contact, you want the foot not to slap down, you want that foot to just go slowly and gradually. You want to load the brace and get a spring-like effect. That's energy storing. Measuring that and figuring out how much energy storing to put into the brace is really the hard thing, because we just don't know how much load you're going to put into it as you're trying it on. In prosthetics, because of money and there's just more research into it, they're able to really quantify how much stiffness or flexibility to add to the prosthetic feet. In braces, it's hard because you just don't put a component on the bottom. You have to conform it to a limb. And based on the contours, it's going to affect how much energy to put into it. So that's energy storing.
We have time for one more question.
And the question I'd have is the braces, we noticed some of the braces have support on the front of the calf and some on the back. Is there any benefit to one or the other?
Yes, it's based on your need. A posterior calf brace works best for toe pickup. It works best for decelerating the foot. But when you start going forward and loading the toe, you need some resistance. As you get to get that resistance, we shift that cuff and put it in the front. So you're almost leaning against the brace. And in order to do that, you also have to have a full-length foot section so that you're capturing some of that energy on the shin. And that's beneficial, but it's only if you need it. If you have a weakness of push-off, you want to have a flow reaction AFO, which is in the front versus a posterior.
Rudy, can you put your contact information back up on the screen so people can see how to get in touch with you all?
Sure. I guess you have it in your slide.
Let me just, while they're doing that, let me just make a comment, because we see so many people come to us who either are not wearing their braces because they don't feel good, they're not right, they don't work, they don't like them. And the question is, how can we avoid that? And really, it's a matter of a team approach to kind of sort this out. So I don't know about all the orthotics. I know a lot of braces are designed for people with a foot drop. Lots of causes of foot drop other than CMT. CMT is unique in many ways because of the foot deformities, because it's not just the foot drop, it's the ankle instability and other issues. And so you really need someone who's actually worked with CMT. Otherwise, you may just get from an orthotist, this is what we do for foot drop. And so getting to someone who's really knowledgeable, making sure that your needs are the specific needs being addressed. And this again is where sometimes these clinics, our clinic and I would believe Stanford's clinic, can also help you in terms of trying to make sure that the brace you get is the right one for you. Now, you can never be sure, but I think you have a better chance of working with a team. So frequently in our clinic, Rudy and Glenn and Don are all in the room together with you, trying to sort out what is the best approach for your ankle and your foot. And so it's a team approach that comes together to try to sort this out. So be careful about the brace you get, and maybe if you're not sure that orthotist knows CMT, go to another orthotist, or go back to your doc and say, do you know of someone, or your physical therapist who really has worked with this? Because it really upsets me when I see someone has used up whatever capital there is, whether by insurance or themselves, getting a brace that sits in the closet.
I agree.